I was very tempted, I was saying to Derek earlier on, that to do a John Alexander Williams here and have my second slide and say none and walk down from the podium. Can I qualify that by saying I think there are papers that change practice, but they do it in incremental bits. It's nothing profound that hits you like a tidal wave. Now, as you know, the BJS covers a whole variety of topics. Being a colorectal surgeon, a lot of what I'm going to say today is biased towards the colorectal, because I feel a bit sort of out of my comfort zone. And to quote Des from a previous presentation on this, I was looking for papers initially that maybe produced ripples that then eventually would form some sort of tidal wave of change in practice. There are some like that, but you have to take one step back with a lot of them. And of course, some of those papers will change practice positively and others negatively. I looked at the, hang on, this is going just continuously, dear Derek. Can I slow it down somehow? I'm not touching anything and it's just going.
Can we stop the presentation and go back to the start, please?
It's on continuous roll there. Let's try again, shall I?
Yeah.
Getting nowhere now.
Whoa. This is
no problem.
Fire away. Seconds start. So, well, you heard all that then, 30 So now we've got to wing it for 30 seconds. That shouldn't be too difficult. John, do you want to do it, or do you want me to wing it for 30 seconds?
I'd just like to hear what you say for 30 seconds.
For 30 seconds.
I mean, I saw all your meetings going. Are you sure you can say something
well,
for 30
I tell
minutes?
you, I mean, I was interested. Des says that, you know, PPIs knocked spots off highly selective vagotomy. I mean, come on, it was that funny bug, wasn't it?
Yeah.
It's all to do with that H. pylori stuff, which, of course, itself is an interesting thing, because if you look into the history of it, I think it's right. See, here's a man. He gets a Nobel Prize for his work on H. pylori, and his first attempt to present that work at an Australasian scientific gastroenterology meeting resulted in rejection of his manuscript. So,
I think we've got to go, Derek.
So some people can get it wrong. Well, there you go. There's 30 seconds of something useless. Yeah. And away you go again, John.
So back to Des's comment. I was looking for papers that cause these ripples that might cause a future tidal wave of change. And, of course, some of these papers will change things positively, some negatively. So I naively thought, OK, what I'll do is I'll get our in-house editors to look at the most cited papers ever in the BJS. And here we are, the most cited paper ever, by far, 3,900 odd, is esophageal transection, which was popular at the time, but certainly, as Des was commenting, we don't do now. But interestingly, the next paper along was that of Bill Heels on the mesorectal issue. As you can see, I mean, look back at Dennis Burkitt's paper from '58. You know, these are, at the time, big papers, but of no relevance today. So I took down to the last 30 years instead, and again, Bill Heald was featuring there. So I'm going to start talking about that particular paper to start off with, because it's a very good example how things change, sometimes take a step backwards, and to put things in perspective. As you remember, Bill made a major contribution pointing out about the distal spread within the mesorectum in rectal cancer and the importance of excising the whole of the mesorectum. But did it make a difference? Without question, it made a difference. This changed the whole generational issue of rectal cancer surgery within the UK and Europe. And the European mainland took it on in big time and found major improvements in their local recurrence rates. And then subsequently combined that with preoperative radiotherapy as part of their treatment regime. And you can see these papers from the Dutch group and from Stockholm showing the impact of surgical training of TME excision in the treatment of rectal cancer and the increased and improved outcomes that they had. But it did change practice negatively as well. Yes, no question it did. because that generation of surgeons applied TME excision to abdominoperineal resection. And we had the wasting of the surgical specimen that produced unacceptable rates of local recurrence. And Bill put his hand up about this in a published, it wasn't published in BJS, but subsequently, where he was quoting local recurrence rates because of this wasting of 33 to 47%. This then brought forward the concept of ELAP, which we're now all familiar with today, of the extended resection around the perineum, avoiding the wasting, either combined with or without preoperative chemoradiotherapy. It's an example there of a major step forward in outcome measures, but another step backwards when applied incorrectly to the tumors of the lower third of the rectum. I thought I'd go back and look at the history. I said about the increments of change, and I went back to see an old mentor of mine's paper in 1969. Peter Hawley wrote on the treatment of fissure in ano, and classical pictures of sphincterotomies either through the sphincter itself or the lateral sphincterotomy, which we're more familiar with today, and how things have changed. And I picked this for a whole variety of things because it's a transition over many years. First of all, my ex-colleague in Swansea, Chris Gibbons, is actually a vascular surgeon, but it is work on anal hypertonia with Nick Reed's unit in Sheffield, I think it was, looking at the high-pressure internal anal sphincter and how the work progressed with a disruption of the sphincter injury, demonstrated after anal dilatation, and then the knock-on effect on the various chemical instruments we use today, diltiazem, nifedipine, Botox, and whatever for treating fissure. So you can see a progression over the years of how things change incrementally, both in the BJS but also in other journals, because you find these things flit back and forth between various journals, people publishing in different sites. But is there a place, at the end of the day, for sphincterotomy? Yes, there is, because these treatments are not absolute. Patients fail on these treatments, they recur, and there is an argument in selected cases carefully for sphincterotomy. I'm going to infringe on what Keith said about ERAS earlier on, but it's another example of how things have progressed over the years. First of all, with the nasogastric decompression, although Keith's pointed out some papers by Laurie Tinkler many, many years ago, and how that has had an effect on the ERAS program, which we're now very familiar with. Part of that is the mechanical bowel preparation story, and that goes back to John Hyland's work back in 1994 and right through to the current times in 2007. And I was having lunch with Mike Parker earlier on, and we were discussing the outcome measures related to these mechanical bowel preparations. And what's been looked at in the past are the immediate outcome measures, the leak rates, the infection rates, etc. What's now coming out, from what he tells me from a recent meeting, is that patients who have mechanical bowel preparation have actually got better local recurrence rates and survival rates overall than the patients who don't have mechanical preparation. And this is from large studies in Sweden. So things are changing. There's a flit towards one direction for short-term outcome measures, a flit back potentially again now with more long-term measures which we're more concerned about. I'm going to flit very briefly into upper GI, though as I said, I don't feel very comfortable in this area. But there are some things that have changed practice in the BJS over the years. A paper that Derek published about lymphadenectomy and the proximal lymph nodes in esophageal cancer, and if these were involved, that you really shouldn't be considering surgical resection. The new work on totally minimally invasive esophagectomy, a good study. And again, importantly, just to point out that not all the papers that change practice, like the Bill Heald paper, are randomized controlled trials. This paper from Wynne Lewis's unit in Cardiff highlights that very well. Matthew Morgan, who was the research fellow with them, found that if you looked at a group of patients who were having esophagectomy, either with or without radiotherapy, the local recurrence rates and the overall survival were no better, and questions the use of these modalities in this treatment. And obviously it needs an RCT to sort that out. The progression of benign upper GI surgery has gone over the years, starting with preliminary result findings in lap Nissens as an example, through to the 10-year survival outcomes more recently of lap Nissen versus partial fundoplication. So there's a change, a progression. It's never something that's absolute and defined at any one point in time. Just to mention a few more speculative areas recently, you've seen the advent now of laparoscopic surgery for appendicitis, but more recently again, the fact that a lot of patients now are being primarily treated with antibiotics on the basis that it's successful and the risk of being a recurrent appendicitis is actually relatively low. Then there's what about diverticulitis? The paper that Des published in 2008 looking at laparoscopic peritoneal lavage highlights the fact that we don't need to be doing multiple Hartmann's procedures for these patients on laparotomies. They can be treated quite successfully by lavage and drainage, and a very small proportion of these patients actually go on to needing a definitive resection. And Frank Frizzell has highlighted that in papers from New Zealand, where if you look at the whole group of patients, it's only a very small percentage of patients who present with acute diverticulitis that actually need definitive surgery. More interestingly are these two papers at the bottom here, which are now highlighting the fact that in a large proportion of patients with acute uncomplicated diverticulitis, there's no actual need to treat them with antibiotics. The outcome measures are virtually the same. I thought I'd digress for 1 minute because we were sitting in the editorial group meeting some months ago, and I randomly just opened a BJS copy that was there from the 1960s, and the paper I came across was this from David Patey. And his operation is defunct these days, as Des was discussing earlier on. But it was interesting to note the work that he did on axillary clearance and the Patey operation and identifying the lymph nodes involved, and how that has progressed over the years to what we're now dealing with, if I can get the slide to go forward, with a sentinel nodes, ultrasound-guided biopsy, and the way that we identify these patients in the surgical setting. The other things that really have changed in the breast world is the change of the use of tamoxifen, which in my junior years, a lady came in in her 80s with a breast carcinoma. Invariably, if they weren't fit, we put them on tamoxifen. That's now been disproven in this very nice follow-up study. And more recently, there's a multi-center thing on the intraoperative molecular analysis of sentinel nodes, looking at cytokeratin as a marker intraoperatively in these patients. What about the future? I put these up speculatively. One of them I don't think has been published yet, but it's online, is the first one is the transanal total mesorectal excision, a paper we published very recently, and the one that's coming out very shortly, if it's not out already, is transgastric appendicectomy. And one, I think, which may have a major effect is the use of volatile exhaled organic compounds in identifying patients with colorectal cancer. Is this going to change the way we screen patients in the future? What effect will these sort of patients have 10, 15, 20 years from now? Thank you very much.